I want to welcome you all to this symposium on successful aging. This is the first joint program with the Case Western Reserve University Schools of Dental Medicine, School of Medicine, and the Francis Payne Bolton School of Nursing. As you all know, these three schools of Case Western Reserve were joined together in this marvelous Sampson Pavilion last year. The vision that Toby Cosgrove and Barbara Snyder had, championed by all three deans of the schools, is revolutionary for education. When I became the president of the School of Dental Medicine Alumni Board, I wanted to do something for our organization that would go along with this vision. Since students will be learning and interacting together in this pavilion, I felt that those relationships should not end at graduation. It is my hope that by beginning to merge our various alumni organizations together now, those relationships will continue throughout all of our lives. This symposium on aging was my idea to begin the process. Hopefully, this will be the beginning of interactions between the schools and perhaps end up one health science alumni organization in the future. In March, when our university, along with so many others, went to remote learning, the question we received from most alumni was, how will the students get their clinical experience? Many of us had to close our own dental offices or offer just emergency services. The school's dental clinic was no different. It closed, and when it was safe to do so, the clinic reopened, offering emergency services provided by the residents of some of our specialty programs. The summer was the time of tremendous transformation for the dental clinic in order to adhere to requirements set forth by the CDC and the university. These will include many of the same enhancements many of us did for our own offices. It was an uncertain summer, and I heard that the students came through it with minimal challenges. They were flexible and embraced these changes. I am sure there were many frustrations, just like what we encountered in our own dental practices. I want to thank Dean Chance and the school's leadership team for diligently working to ensure the students meet the same requirements, even enhancing areas where they could. I'd now like to introduce Dr. Saperna Mahalaha. Saperna Mahalaha, DDS MPH, earned her dental degree from Case Western Reserve University in 2001 and completed her general practice residency at the St. Louis Stokes Cleveland VA Medical Center. She also holds a master's in public health from Case Western Reserve University and is a fellow with Special Care Dentistry Association. Dr. Mahalaha joined Care Alliance Health Center in January of 2009 as a full-time dental provider. Serving on the dental team for over 11 years now, Dr. Mahalaha has been appointed as the Chief Dental Officer and has been instrumental in the growth and expansion of Care Alliance's dental practice. Dr. Mahalaha enjoys caring for patients of all ages. However, she has a special interest in the care for geriatric patients. In addition to working at Care Alliance, Dr. Mahalaha also serves as the Assistant Professor at the Case Western Reserve University School of Dental Medicine and is the Director of Lifelong Smiles Geriatric Program. Saperna Mahalaha will discuss the current challenges and opportunities of the oral health needs of seniors. She will share the future of a CWRU School of Dental Medicine program, Lifelong Smiles.
Good morning, everybody. And I wanted to thank Dr. Alperin for introducing me. And thank you for joining us on this Saturday morning. In the spirit of Alumni Weekend, I pulled out this old Case Western sweatshirt that I got in 1994 from the Twing Bookstore on Euclid Avenue as an undergrad freshman. I've been at this university for many years as a student and now as a faculty member in the Department of Community Dentistry. I've always been grateful to be a part of this university, and I'm so happy that I get to engage in work that I truly believe in. And I want to spend a little bit of time this morning talking to you about what we're doing at the dental school in the Lifelong Smiles program. And this is our focus on dental care for the older adult in the community. Before I want to get into my presentation, I wanted to share a picture of my favorite older adult. This is my grandmother. She's 94 now, and she lived with us for many years. And I think growing up with her, I learned a lot about preserving dignity while one ages and the need for independence for as long as possible. And I called her up before to make sure I could use a picture of her, and she did tell me to use a good one. So as we know, the population is aging quickly, in our country and globally. By the year 2030, the number of American adults 65 years and older will reach up to 72 million. And that's going to represent about 20% of the population. This is a growing demographic for dental practices now, and also for the next generation of dentists. 18% of adults 65 years and older with retained teeth have untreated caries, and 68% of these patients also have periodontitis. So in spite of advancements in dentistry, untreated caries and loss of dentition remains relatively common for the older adult. Comorbidities can worsen oral health, and poor oral health can then exacerbate medical problems. 1 in 4 older Americans are edentulous. 25% of adults 60 years and older no longer have natural teeth, but this does vary by state, with West Virginia at 42% and California at about 13%. The barriers to care are varied and complex in that only 46% of older adults visit the dentist. And there are many reasons for this. Transportation challenges, there could be a physical or a cognitive disability. The older adult could be homebound or institutionalized. The number one reason is cost. 70% lack dental insurance. Medicare does not cover preventive and outpatient dental treatment. Medicaid dental coverage varies by state and is limited, and often does not cover routine preventative services. Unfortunately, even as one ages, the fear of the dentist does not go away. Another barrier to care is available dentists to treat this group. Also, concerns we've heard about is patient-friendly dental offices. Is the wheelchair access adequate? Are there access to restrooms close by operatories and in lobbies? And generally oral health is a low priority, patients, caregivers, and healthcare staff. And again, for good reason. There are competing medical priorities and also the level of oral health literacy. The needs are great, and we have a lot of work to do. We need to have a comprehensive increase in oral health literacy for older adults and their caregivers. We need more community-based programs promoting oral health. And we really need more comprehensive interprofessional collaborations. And some of that is starting. We need more of it. We need more consistent messaging about oral health in relation to overall health and well-being with all of our partners, in medicine, nursing, social work, pharmacy. If we can layer that message, it helps our older adult population. And there's a great need for insurance reform, especially with Medicare. I know this bill has been in the Senate for a few years now. We're hoping for some reform, some coverage. And also with Medicaid, the reimbursement rates are pretty difficult and challenging as well. And again, do we have an available dental workforce, not just in the urban centers, but also in the rural areas where more older Americans are aging in place? So in 2014, Dr. James Lalamander spearheaded the program. He was able to acquire a 38-foot-long mobile dental van from the State Department of Health. And we had initial funding by the McGregor Foundation and also with the School of Dental Medicine. Dean Chance continues to be really supportive and encouraging the program, and we really appreciate his support. So back when we started the program, Dr. Nicole Harris Nelson, who's a dear friend and a classmate of mine when she was working with us in the program a few years ago, we came up with a couple goals and objectives for the program. And it's not a typo on the screen. I didn't forget to put goal 2. I think both of these goals are number 1. We want to be able to provide comprehensive dental care for older adult patients who cannot access dental care traditionally. And it's also number 1 goal to provide educational experiences with older adults for our dental students outside the dental clinic. It's a picture of our van. It's got 2 dental chairs, a wheelchair access lift, sterilizer in the back, digital x-rays. It's pretty tight in there, but we make it work. Our driver, Gary Sislak, takes very good care of this van. So we're able to deliver care in the van and or with mobile equipment that we have to take inside facilities. And that is challenging, but we do it if the weather is not suitable for our patients to come walk outside to the van. You know, if it's raining, if it's icy, if it's cold, we'll take our mobile equipment and go inside. When we started the program, we made a choice to focus on adult day centers. And adult day centers are non-residential facilities that delay the need for assisted living or nursing home care. So we really focus on the older adult aging in place, aging in their own space. And adult day centers will then provide social and health services for some parts of those days and provide transportation to and from where they're living. We currently work with 3 adult day centers in the area, McGregor Pace facilities, the one in East Cleveland in the Forest Hill campus, and then also in Warrensville Heights. We also work at Eliza Bryant Village, which is in the Huff neighborhood, very close to the dental school. And also we go to the Jewish Family Service Association, which is the Allison's Place Medical Clinic. Between these 3 facilities, we had them on a monthly rotation. A picture of a couple of our students working on a day when we had to move inside, and our requirements for that is a little bit of space, a sink, and a way to close the door. So this particular day, I think we were in one of their medical rooms. We do use ProCart 3 mobile equipment. It's really great, compact, dependable, and on wheels. So that's what we use when we go inside the clinics. We provide comprehensive dental care. Exams, x-rays, cleanings, restorations, extractions, dentures and partials. And we do work with the local dental lab as well. We do refer back to the dental school as needed into our DMD clinics or our specialty care clinics. And our assistant, Aisha Kistner, makes sure to follow up on that referral in terms of making the appointment, connecting the patient to the clinic, talking to the adult day center about transportation. So we make sure we close the loop, and she works as a navigator for some of our older patients as well. This program is a mandatory clinical rotation for all 4th-year dental students. And what I love about it is that we're able to provide interdisciplinary experiences because we're in these centers. And in these centers, the older adult can get their medical appointments, their medications, meals, breakfast and lunch, PT visits, behavioral health visits, and then also socialization. Depending on the year, one year we had pharmacy students who were rotating through the center, and our dental students got to work alongside them and do their medication assessments with those students. Dr. Peter DeGolia, who is the medical director at McGregor Pace, shares his time and is very generous with the students in that he lets them observe with him when he does his rounds and goes into the nursing home facilities, or even when he's working in the adult day center. So there's really great opportunity to learn more about complex medical issues and the many medications that some of these patients are on. We also do promote educational outreach in nursing homes, community health fairs, and assisted living facilities. Our assistant leads up that program, and as faculty members, myself and Dr. Lisa Blackman, and also the students, when we're able to, when their schedules are available, we take them out for these outreach events too. Here's a quick picture of the inside of our van. It's pretty tight, but it's nice when the students come on, they're like, wow, this is really small. But as the day goes along, and as the rotation goes along, we find out how much work we can do in a small space, and everybody really jumps in and helps each other. The picture on the right is a couple students who were getting ready to take impressions for a patient. The patient's wheelchair was too wide for our lift, so we had to take the patient back inside, and we had to do the impressions indoors. And it was a challenging one. I think they took these impressions 3 or 4 times. The patient had a large tongue. The patient was hunched over, but I think it was a great experience, and I got positive feedback about it afterwards from them. So we're currently at about 850 patients counting right now, patients we've treated. We've driven 4,000 miles. We've educated 2,400 people, older adults, caregivers, healthcare staff, and we've made 275 dentures, partials, and realigns, and counting. So in closing, I wanted to touch on the future of our program and have lots of plans, provided we have the resources and the time. We would like to go to more facilities, offer more care. We want to start using more teledentistry options. We piloted this in the summer, went pretty well, and now looking forward to pushing this out with the students as well. I think we can do more in terms of interprofessional opportunities just between our own Case Western professional schools. There's so much we can do, and there is a lot of work going on in that space. I would really be happy to see us in a nursing home and running a student clinic, and also explore home dental visits. We get calls weekly for patients and caregivers who are asking us to come into their homes. We're just not set up for that right now, but it's definitely something we're looking forward to in the future. So thank you for your time, and I think we'll be taking questions at the end.
Good morning. My name is Jim Fleming. I am president of the Case Western Reserve School of Medicine Alumni Board. I want to give you a little overview about the School of Medicine, our mission, and some of the things we're doing in the School of Medicine. The School of Medicine's mission is three-pronged: providing the best education to our medical students, including our leading-edge Western Reserve II curriculum. It was founded back in 1952 and has been innovating ever since. We also advance medical breakthroughs from lab to life, and our goal is to improve the health and wellness needs of our community. This includes identifying and addressing disparities and the social determinants of health. We are proud of our faculty and staff who aren't satisfied with how it's done, and of our students who strive for further greatness. As we guide our students, we embolden them to reach for new experiences and achievements. Our students match at the very best institutions in the country. 40% of them match at top 10 ranked hospitals. And I'm also proud of the fact that our 228 students who matched this year in all areas, 49% were women. This year, we broke records in most applicants ever received and have admitted a class with the highest MCAT scores we've ever had. 50% of these students who were matched were women. We teach students to think like doctors from the moment they walk in the door, and our small IQ group model fosters these skills. In addition, we've developed pathways and programs that complement their MD training in specialized areas such as world medicine, innovation, entrepreneurship, and the most popular, wellness and prevention, which is all evidence-based. We are proud of our tradition of advancing research as well. We have a long history of leading the way not only in medical discoveries, but also in moving these discoveries through the pipeline to market as new therapeutics that can improve outcomes for our patients. We've had many wonderful research achievements, particularly in large collaborative or competitive grants. Collaboration has long been a hallmark of the School of Medicine, and this collaboration has been both interdisciplinary between the cities and hospital institution and nationally. We've been hard at work fostering the culture of entrepreneurship at all levels, including students, which we'd like them to understand the breakthroughs that they can't exist in a vacuum. We have an ever-increasing number of these important discoveries moving from the lab bench to patient care. And another point of pride is that we are number 20 in the United States for NIH funding. Our commitment to health of our community is paramount of our success and is the third pillar of our mission. We have a deep connection to our community and are proud of our role in so many programs that solve real problems and for the people and families in our local neighborhoods and community. Through our partnership with the Cuyahoga County Board of Health, we played a major role in responding to the COVID-19 pandemic. Faculty members Heidi Gillette was named incident commander of this institution, and she's led the county's efforts in investigating infection in our vulnerable groups. She's advised the community for best practices and helped refine predictive modeling for the region. In addition, more than 100 School of Medicine volunteers stepped up to help at the Board of Health during this critical first few months of the pandemic. The School of Medicine is proud of its long history in three areas outlined and mentioned, and we are excited for a bright future alongside with the dental and nursing schools in which we continue our tradition of education and discovery. I'd now like to introduce Dr. Jonathan Haynes, PhD. Jonathan Haynes, PhD, is an internationally recognized researcher and educator with extensive experience in all aspects of genetic epidemiology. He's had a particular focus on data analytics. He has applied his expertise to numerous neurological and ophthalmological disorders and is credited with locating more than 20 causal and 200 associated genetic loci. He advocates for diversity in genetic sampling and a comprehensive view of data analytics. He recognized the environmental and social impacts can form genetic expression and biomedical outcomes. Dr. Haynes is the Mary W. Sheldon, MD, Professor of Genomic Sciences and Chair of the Department of Population and Quantitative Health Sciences at Case Western Reserve University School of Medicine. This is the administrative home of the Cleveland Institute for Computational Biology, which he founded and directs. The Institute is a collaboration among Case Western Reserve University School of Medicine, University Hospitals of Cleveland, and the Cleveland Clinic.
Well, hello and good morning, everybody. I would like to thank everybody for coming in and listening to our presentations today. And I want to thank Jim for the kind introduction and the opportunity to speak a little bit. I will be talking a little bit about our activities and research looking at Alzheimer's disease and looking at it in a somewhat different way than most people have. So I'll give you a little bit of background and then tell you a little bit more about what we are actually doing. So Alzheimer's disease, as I'm sure most of you know, is a very, very common disease of older individuals. Currently, it's estimated that there are about 6,000 people in the U.S. that are afflicted with Alzheimer's disease. It's characterized by a continual decline in both memory and cognition. And over here, I have a diagram of what a healthy brain and what an Alzheimer's brain looks like, which is, obviously not the way you would like it to be. And then within the neurons of the brain, the classical characterization of Alzheimer's disease are these little tangles inside the neurons and these amyloid plaques that are outside the neurons. Usually, Alzheimer's disease starts after age 70, but there are some that start before that. The treatment options are very limited, and they only treat the symptoms and not the underlying causes. So this is a big problem. We really don't have a way of dealing with Alzheimer's disease at the moment. All the drug trials that have ever been done on Alzheimer's disease have failed, which is a little disappointing, but a lot of that has been because I don't think we understand enough about Alzheimer's disease. And up to now, the focus of virtually all the research on Alzheimer's disease is to try to understand what causes Alzheimer's disease. And one of the causes, and one of the causes that I work on, is that there are genetic factors that strongly influence the risk of Alzheimer's disease, the strongest of those being the ApoE gene. So this just gives you a little bit of a diagram of the history, how long we've been looking at all of this to try to understand the genetics of Alzheimer's disease. The first breakthrough really was in 1991 with the finding of that very first, the rare variants in this very first gene. ApoE showed up a little bit later, something that I was involved in, and then after a series of additional efforts, and I call this the dark years over here, because there was a lot of work being done, but not a whole lot of progress happening, and part of that was because we just didn't have the right genetic tools. Starting in about 2007, those tools actually got to the point where we could make some progress, and we've now actually made quite a bit of progress being able to look at more and more variants across the genome and identify which ones might be involved in Alzheimer's disease. So this summarizes about 30 years worth of work in this one slide, And the major point here is that the ApoE gene, the effects of the ApoE gene, still represent the largest fraction of what we know about the genetics of Alzheimer's disease. And there's been a lot of work done over the last few years to explain some more of this. But the majority of the genetics of Alzheimer's disease is still not known. And this is where some of the focus of our research has been, is to try to understand what's going on there. But while we were looking at that, and we're still working on trying to understand those things, we thought that maybe we should take a little bit of a different approach to how we try to understand Alzheimer's disease and how we try to help get over the fact that all those drug trials have failed. So we know that some people have many of those plaques and tangles that are classical for Alzheimer's disease, and yet they are perfectly normal. They do not have the clinical symptomatology of Alzheimer's disease. We also know that genetics is very important, as I've just said. So we hypothesize that there are genetic factors that delay or protect individuals from the onset of Alzheimer's disease. So sort of looking at the other side of things. So we decided that why not look for the genetics that keeps us well and keeps us cognitively normal? What is it that's protecting these individuals from developing Alzheimer's disease? So we've developed a rather unique approach to try to find these genetic factors. And this approach takes advantage of some natural populations that are here in the United States, and particularly in Ohio and actually in Indiana as well. And that is looking at the Amish communities. So the Amish emigrated from Western Europe in the 1700s and 1800s, and this was primarily due to religious persecution. They practiced religious and cultural isolation from other individuals. That's how they maintained their beliefs and their lifestyle. This isolation and their lifestyle increases the homogeneity of environmental exposures. We know that some environmental exposures are important in Alzheimer's disease, but this reduces that. Formal education, and education is one of those factors, typically stops at the 8th grade. There's virtually no smoking or alcohol use in these individuals, and that reduces that background variability, which allows us to look at the genetics more clearly. They marry mostly within their faith. There's not a lot of use of birth control, so they have very, very large sibshifts, which gives us large families and large interrelated families, and that makes us, when we're looking at the genetics, gives us some advantages there. So this is also a genetically isolated founder population, so they're all descended from just a few hundred individuals, and that can amplify the effects of rare variation. It allows us to more easily identify those. So working with the Amish is very interesting and is very, very rewarding, but we can't use the usual approaches to identifying these individuals. We can't, they're not typically coming into the clinics in the big cities. So, and they don't tend to use modern conveniences, so there's not a lot of use of phones or modern communication. So most of our ascertainment, most of the way that we try to enroll individuals into our study is door to door. We actually drive down the roads and knock on the doors, or through the mail. And we do that in part by having our ascertainment personnel live in and around the community. So our ascertainment personnel for Central Ohio actually live in homes in Wayne counties. And they live there, they know the communities, and so it works really well, and they're very well accepted. And we have managed over the years to probably ascertain and enroll about 35, a third of the Amish population over the age of 65. So we want to take advantage of the unique nature of the Amish families. And I have here on this diagram a diagram of sort of a typical 3-generation family. So the squares are males and the circles are females. And so this is the grandparents, and they had 3 kids, and 2 of their kids had some grandchildren. And this is a fairly typical pedigree. It's actually fairly close to my own. But the Amish are a little bit different. As I said, they tend to have large families. They are descended from a small number of original individuals, and they typically marry within their faith, so they're marrying other Amish. So rather than having this kind of family history, family pedigree, this is the kind of thing that we see. So we are able, because they have very, very good genealogical records, to connect virtually everybody up into this single 12-generation pedigree. And you can see all these lines are all the connections and interconnections, and you can see that it's very, very complicated. It provides us some really interesting ways of looking at the genetics, but it also makes looking at them a pretty complex approach. So how are we actually going about trying to identify these protective factors? We're doing this by trying to identify cognitively normal individuals who are at high risk of developing Alzheimer's disease, but have not developed Alzheimer's disease. And our criteria for this is that they need to be cognitively normal. They need to be doing well. And we do that by doing a number of different neuropsychological tests. We're looking at individuals only after the age 76 and older. And we have enrolled a few individuals who are over 100 years old. And then they have to have a high risk profile. One of those is that they have a sibling who's been diagnosed with Alzheimer's disease, or they have that ApoE4, which is the high risk variant of ApoE. Or if we look at all of that, or the genetics, and say that they have a higher risk because of all the other genetics that they have. And over on the right here, I have an example of some of the SIB-ships that we've looked at. You can see they're very large. The numbers in here, if you can read them, are the ages, and so we have individuals at age 97 and so on. And these are the SIB-ships that we are going and trying to ascertain and bring into our studies. So where are we so far? We've been doing this for about the last 2 years. Obviously, with the current pandemic, we've not been able to go out and continue to enroll in person these individuals. So we're a little bit on hold on that aspect of things. But what we've got so far is we have DNA samples that we've gotten from blood on a total of about 2,200 individuals across Ohio and our collaborators in Indiana. And that includes samples that we've collected over the years for other studies as well. We've examined 725 individuals for this particular study. Of those, more than half of those are cognitively normal when we do the examinations. There are a number who have somewhat uncertain results, and we'll have to go back to them. And then we have a number of individuals who turn out to be cognitively impaired when we actually examine them. So we have those, and then from our previous studies, we have another 260 or so cognitively impaired individuals, and that becomes important for our comparisons and how we compare between cognitively impaired and cognitively normal individuals. So what have we found so far? So we've done a very, very preliminary analysis on 7 million genetic positions across the entire genome. And this diagram over here is a diagram of the different chromosomes, the 23 pairs of chromosomes that we have. And what we've found so far is that there is a signal, and we don't have the actual variation yet, but there is a signal showing up on chromosome 18. So this one smaller chromosome here. And within that, we think it's down at this end of the chromosome. And I realize that this diagram over here probably means nothing to most everybody, but we get real excited when we see little peaks like this. So this is where we're likely to continue to look to try to identify what variation is actually there. So that's a preliminary look. What are our next steps? Our next steps, we're going to not look at just 7 million variations across the genome, but we want to look at every single position across the genome. So we are actually going to do what's called whole genome sequencing on 1,150 of these individuals. About 430 of them are cognitively normal, and about 450 will be cognitively impaired, and we'll be able to do the comparisons across them. We will examine the 3 billion different positions across the genome to try to find the protective variations that we believe are there, and as our preliminary data would suggest that it is. And then, and I certainly won't go into any of the details of this, we are using a number of statistical and computational methods to sort through all of these positions and try to understand whether or not they have an impact on the cognitive preservation of these individuals. And we have to account for that hugely complex pedigree that we have and look at how these variations are passed through the family and the subfamilies and all of that. And that takes a lot of statistics and a lot of computational power. We are using the university's high performance computing center. We're one of the bigger users of that center right now because we are constantly putting analyses out there that sometimes takes days, even weeks to run across that system. And so that's where we are. We're hoping and we're planning. We should have these data by the end of this year, and then we'll be able to go into a very, very high level of analysis to try to identify these individuals. So we're really hoping that we can identify something that will give us a clue as to how people have cognitive preservation, and maybe use that as the first step toward trying to identify a therapeutic of some sort that would follow along those same mechanisms and be able to help people prevent from developing Alzheimer's disease. And I believe that was my last slide. And so I also think we're taking questions at the end. So that's the end of my talk, and I appreciate everyone listening.
Good morning. I'm Pat Beam, president of the Francis Payne Bolton School of Nursing Alumni Association Board. FPB is a globally recognized leader in nursing education and research, and we are preparing the next generation of nurse leaders. 2020 has been designated as the year of the nurse and midwife, and during this year, our country has faced a global public health crisis while also coping with events that have sparked a wave of renewed advocacy in the areas of healthcare equality and social justice. The world is witnessing how vital they are to our society. Our FPB community continues to respond swiftly by providing transformational leadership on many fronts. We have provided frontline care in the fight against COVID-19, implementing contact tracing initiatives and supporting community outreach efforts. We have developed educational materials and how-to guides covering everything from hand washing to advocacy. We have launched a national study to understand how perceptions of and responses to the pandemic have influenced self-management behaviors and symptoms. We are training health professionals to provide telehealth COVID-19 screening and testing, providing outpatient care, and supporting COVID-19 workforce training activities. And we are providing unprecedented opportunities for nurse leadership education to our BSN, advanced practice students, and executive nurse leaders. For all of these reasons and much more, we themed our Homecoming 2020 as leadership looks like you, whether on the front lines, serving our communities, conducting critical research, educating our amazing students, volunteering on boards and leadership committees, or generously supporting our FPB Nursing Strong Together campaign. Our alumni community continues to lead, respond, and adapt, ensuring Francis Payne Bolton School of Nursing continues as the nurse leadership destination. And now I would like to introduce our presenter, Dr. Mary Delansky. Dr. Delansky is an associate professor and director of the Quality and Safety Education for Nurses Institute at the Francis Payne Bolton School of Nursing. She also serves as the National Nursing Director of the VA Quality Scholars Program and is the senior faculty for the VA Quality Scholars Program. Dr. Delansky has a long history of advancing the quality and safety of care for older adults through NIH and foundation funding. She is currently leading the implementation of the age-friendly health system into CVS Minute Clinic. funded by the John A. Hartford Foundation in partnership with the Institute for Healthcare Improvement. In 2020, the 1,100 Minute clinics across the country will provide tailored care that integrates important aspects of mobility, mentation, and meditations during every clinic visit, with a goal to raise awareness of the importance of age-friendly healthcare to prevent harm to our older adults and improve health outcomes. Dr. Delansky will share her work on the age-friendly healthcare being introduced nationally at CVS Minute clinics, with an emphasis on quality and safety for older adults.
I am delighted to be here today to talk about successful aging. I'm honored to be along with our esteemed interprofessional colleagues here and really enjoying the presentation so far. I want to take just a little reflective moment on the past 10 years of interprofessional education at Case Western Reserve University. And going from siloed nursing school, dental school, medical school, to really moving toward our health education center and being able to work collaboratively with all professions. And this new building really is providing many opportunities for all of us, not exactly this year in COVID, but once we're back in full-fledged work, I think that we will resume our great interprofessional dialogues in this wonderful building that we have. I also would like to just highlight some of the centers at the School of Nursing that are interprofessional and do target and lead to better health care. That is first our Cusin Institute, the Quality Safety Education for Nurses, that has an international resource center for all professionals on how to really implement quality and safety competencies in practice. The care of older adults is really at risk in our healthcare systems today. Possibly 1 out of 5 older adults do have some potential error when they are hospitalized in our current healthcare situation. And the Cusin Institute provides some solutions to how we can better our care. The second center at the School of Nursing is our University Center on Aging and Health, in which they have wonderful courses and a geriatric certificate that any profession can attain, and also leads research in geriatrics, and also has a big impact on practice. And our third center at the School of Nursing is the Sarah Cole Hirsch Center, ensuring the implementation of evidence base into practice. And it can be evidence in any profession. Currently, we are moving into implementation science to ensure that we're using the current, most up-to-date ways and solutions on how we can implement all this wonderful evidence that we're obtaining through discovery and research into current practice. So with that, I'd also like to share, along with my colleagues today, that there are increasing numbers of older adults, achieving 77 million by the year 2030, which isn't really too far away if we think about it. And successful aging really involves many dimensions of our human being state. That's our social health, our spiritual health, our physical health, and then also emotional or mental health. And we can ensure successful aging by promoting healthy lifestyles, where we can continue to integrate into our lives exercise, good nutrition, good stress reduction, and also successful aging does depend on good self-management of chronic disease. So successful aging is promoted by interprofessional collaboration. Not only the collaboration between healthcare professionals, but also co-producing health with our patients, with our families, and with our communities. And I think this is an important new step forward in our care delivery, in which we are co-partnering and co-producing health with our elders. So today I wanted to share one of the initiatives that we have currently going at the School of Nursing in promoting successful aging. We are working in partnership with the Minute Clinic at CVS. And our partnership began about 2 years ago when we had a meeting about quality and safety and the meeting with Angela Patterson as the clinical, the chief nurse practitioner there at the Minute Clinic. And we thought that it would be really important to improve care for the older adults in the emerging CVS hubs across the country. And you may be noticing that your CVS clinic and your CVS store, retail store, is changing, where they're converting the store into more of a health hub, where they're taking care of many, many needs of healthcare delivery. This partnership then expanded with very generous funding from the John A. Hartford Foundation, and it guided a collaborative work then with the Institute for Healthcare Improvement. And our goal is to implement age-friendly healthcare into all 1,100 MinuteClinics across the country. And this partnership is really important because the Institute for Healthcare Improvement has a very impressive way forward for doing this implementation of age-friendly care, with many guidebooks and many collaboratives to help us with this. And we want to achieve implementing this evidence-based care for older adults, which includes these 4 M's. The first M is what matters, and that we want to ensure that whenever an older adult goes to any healthcare setting across the country, a hospital or a clinic, home care, pharmacy care, and even in the CVS MinuteClinics, that the healthcare professional asks the older adult, what matters to you? So that intent of the what matters for the older adult is integrated into the care for that older adult. The second M is medications. We want to ensure that every older adult that receives any health care across the country has safe medications that are not harmful to them. And we do know that there are certain medications that are harmful to older adults. We also want to ensure, the third M, that every older adult has been screened for dimensions of mentation, which are depression and then also cognitive status. And so we at the MinuteClinic are screening all older adults for depression through the PHQ-2 and then also their cognitive status through the MiniCog test. And the fourth M that we're implementing, and it is being implemented across all healthcare systems across the country, is looking at older adults' mobility and ensuring that they have safe mobility, and that also that if they have some impairment in mobility, that this is being looked at and they are receiving some interventions and treatments to help them with any mobility issues so that they can maintain independence throughout and have successful aging. So at the MinuteClinic, we're caring for older adults across the lifespan. And this includes acute care and also preventative care and also chronic care conditions, which include hypertension, diabetes, and others. And then the last piece is wellness, where the patients who come to the MinuteClinic do receive health promotion about how to successfully age. And as I mentioned earlier, this is a new avenue for the MinuteClinic currently, because care in the past has mainly been delivered to children, families, but now we are seeing more and more older adults receiving care in the MinuteClinic setting. So how do providers at the MinuteClinic ensure that every older adult receive this age-friendly care at every visit? Well, we have our implementation science to guide our work. And that's where we're implementing practice-based strategies to ensure that the nurse practitioner at the point of care easily can integrate this age-friendly care into a clinic visit. We also have a very rigorous professional development series where we are teaching the nurse practitioners and physician's assistants about age-friendly care. Also, we are integrating a very technologically advanced virtual clinic in which the nurse practitioners are practicing and using simulation and to enhance the integration of the age-friendly 4Ms into their workflow. And then lastly, we have a very extensive evaluation and dissemination plan. So just as one sample of how implementation science is informing our work forward, is that we have integrated into the workflow using the EPIC, which is their electronic medical record, how then the nurse can easily integrate this 4Ms care into the visit, and also to document this care so that we can look at how well we're doing. Another practice-based strategy that we're using is to inform the patients when they come to the clinic how their care will be different and how they are receiving age-friendly care to help them to co-partner with us on their successful aging. We also have some very important tools to help patients to follow and to integrate them into their answering of the PHQ-2 and some of the screening that we're doing. We also provide them with this wonderful brochure that helps to send the message to the patient and the families about how to engage into successful aging and take care of themselves as they age. And you can see that they get some health promotion advice on all 4 of the M's. That would be the what matters, mobility, medication, and then mood and memory. So age-friendly care to promote successful aging is a very important focus for us in the School of Nursing. And we also, through this very impressive academic practice partnership, we can reach so many more older adults as they successfully age. So we want to also thank our funder, the John A. Hartford Foundation, and our partner in this, the Institute for Healthcare Improvement, Age-Friendly Health Systems. I want to thank you for this time with you all in sharing the work that we're doing at the School of Nursing.
Okay, I want to thank all our panelists. This was wonderful. And I think the board chairs here have a couple of questions before we open this up to the general audience for questions and answers. I think, Pat, you have a question you want to ask Mary.
Yes, my question for Mary is, how has COVID impacted the age-friendly health systems movement?
Well, as we all know, COVID has impacted all of us in all dimensions of the work that we do. The COVID actually has heightened the importance of age-friendly care for older adults, particularly with what matters. And as we know, the older adult has been most hit with the COVID virus. And I think it has made many people think about, what really matters to them. Do they want to, if they get COVID, be hospitalized during that time? What are their choices in their decision making for what really matters to them? And I just want to reflect on my mom, who recently fell and probably could have been taken to an emergency room to receive care. So what we did was we did a virtual visit, and I was very clear with the physician that what matters most to my mom was that she stay home and that she not be hospitalized because of COVID. And this messaging for me helped me to co-produce good care for my mom in that she received the care that she wanted that meant the most to her. And so we treated her at home, and she's doing very well at this point. So I think the COVID has impacted our work mostly with what matters to older adults so that they can co-produce their health forward.
Very good. I have a question for Dr. Mahalaha, if I could. Superna, participating in the Lifelong Smiles program provides valuable hands-on clinical experience for the student dentist with this ever-growing population. What non-clinical skills are also developed to shape and enhance the student experience?
So I'm really glad you asked this question. In my opinion, the non-clinical skill set is the most important part of this student experience. And I do have to say, my colleagues and former teachers in the DMD faculty and the specialty care clinics do an outstanding job of preparing our students clinically. By the time they come to us, they're able to hit the ground running with some of these other non-clinical skill sets that we want to develop. When we orient the students for the first day of the rotation, we spend some time discussing the importance of patient management and patient connection. We talk about maintaining eye contact, sitting close, speaking slowly, speaking clearly, and showing respect always. If a patient has a physical or a cognitive disability, how would we engage our patient? I ask them to consider all angles of challenge that their patient might be, having at their home. How does a disability or a physical or mental decline affect how a patient takes care of themselves? I ask them to consider nutrition, consider their living environment, and basically approach the patient in a more holistic way. I find that the experience with the older patient with these students often becomes a lesson in genuine compassion, humility, and pausing for that human connection. And I wanted to share a quick story with you. A few years ago, we had a tall male dental student working with an older, frail female patient who was 95. And after he did his assessment and reviewed her medical history, and clinically examined her, he came to me and said, this patient needs a denture adjustment. It'll take me 5 minutes. It'll be easy. I said, okay, go ahead. So I was sitting back in the office space of the van, I was overhearing them talking. And the patient, in a very soft voice, starts telling him, I'm really scared to be here today. I haven't seen a dentist in 30 years. And then she reaches out and she holds his hand. And she starts talking to him about, who she is, where she was born, what she's done in her life. And then the student sort of opened up too, and, talked about where he was from and what were his plans and what he's going to do after dental school. And the whole time they were talking, they were holding hands. And I thought it was just so beautiful to witness that moment where two people who had 70 years between them found common ground and, had a small connection for a minute there. The patient relaxed, they continued to chat, and the student took only 5 minutes adjusting her denture that had been uncomfortable for decades. And I talked to the student later on and, I said, how did that go? And he told me, he's like, it wasn't just a denture adjustment. It really was a lot more. So I think with the experiences we're giving our students, it's something they almost don't see coming, but when they experience it, I think they appreciate it. I hope that answered your question.
First one's going to be on a more global level, and then I'm going to have a more scientific question. And then I'll be taking questions from the audience or panelists here for our group. So Dr. Haynes, statistically, the majority of patients who die from COVID are elderly. On how do we address this in our assisted living or nursing home areas, as it seems like currently the measures are lacking or inadequate?
Yeah, this has been a concern, I think, for a lot of people for a long time, and really there are a number of things that can be done, fairly simple things actually, that can be done that I think would reduce the possibilities of transmission either into the assisted living facility or across the assisted living facility. For example, one of the things that we have to do when we come onto campus now is we have to fill out a little online form, and it's an attestation form that basically asks us some very simple questions about whether or not we're feeling well. Do we have a temperature? Are we coughing? Those kinds of things. Very simple thing, but it reminds you every day to step back for a second, take stock and say, do I really think that I am still well? And so if you did that for everyone who was going to visit or work in a assisted living facility of some sort, I think that would help. It would just remind people to do it. Obviously, all the other things that we need to do, wearing the mask all the time, washing your hands all the time. I think that's very important. The other thing that probably is not happening at a level that we would really like would be actual testing. Now, you're not going to test everybody every day, but you might want to test particularly the individuals that are coming in and working in the homes. You might want to do regular testing of them to be sure that you're not getting somebody coming in who is asymptomatic at the time. Testing of the individuals in the home would also be of some value. So it comes down to reminding people to be very, very careful and doing a lot of testing and all the typical hygienic things to try to prevent the spread.
I really enjoyed your talk and the unique way you're trying to identify protective mechanisms for Alzheimer's rather than just looking at the disease loci. As clinicians, we're always interested in seeing how some of the genetic findings translate into therapeutics. So let's assume you do your Amish study and you find a gene, et cetera, that's protective for Alzheimer's. What's the next steps in translating that into pharmaceutical or other translational efforts to impact patient care?
So that's a great question. There are a lot of steps involved in doing that. The first thing that we would need to do is to confirm that our findings are real and have other people look at those kinds of things. But then we want to try to understand to some degree what is that mechanism. We can identify the genetic variation, but we need to understand why that variation is actually having this protective effect. Is Is it preventing something else from happening? Is it interacting with other genes? What is it? And so there would be quite a bit of activity in the lab to try to understand that. And then you have to try to take that basic understanding and say, well, is there some way that we can identify an existing drug? Would be ideal that interacts with that gene or prevents that or enhances that effect. This has been done actually for cardiovascular disease with the PCSK9 gene. And so you can translate these, but it does take a lot of time. There's something called the Valley of Death, which is where you have a really interesting and promising result, and then trying to get it into the commercial aspect and actually get it out there is really quite difficult. Making that transition is something that is really quite hard to do. And there are a lot of failures along the way. I mean, you go into model systems to try to understand what's going on, and things work there, but they don't work when you move it to humans. So there are a lot of different aspects to that, and the sort of unfortunate part of that is it does take quite a bit of time to do. But what we're really hopeful for is that we'll identify new mechanisms, new ways of looking at these things, and that maybe we can do that more quickly now, because there are a lot of tools out there to quickly sort through drugs to try to identify which ones might be the most promising to work with.
Thank you. Can I ask a question? I'm kind of moderating some of these questions to Dr. I want to not forgive my pronunciation if I have it wrong. Mahalaha.
Yes, I'm here.
So I was a bit disconcerted that one of the problems with getting dental access to the elderly is transportation type issues. I know in the medicine in the county, a number of counties in Ohio, I think most counties, there's community services provided by government and local agencies where they can pick up patients and bring them to medical appointments. Are those things on board for dental as well, or and is that something that we're working on or looking towards?
Yeah, so that's a great question. Yes, but it's not in a coordinated way. It really depends on what programs the older adult is connected into. Now, if they're in an adult day center, they have that connection for transportation. But if you're a patient or you're an older adult who lives at home, technically by the county, there are transportation facilities, but oftentimes they don't get utilized in the way they should be in the most effective way. So that is still an issue for some patients. Or if patients get picked up, it might be a late appointment, a late pickup, the driver might not come on time. These are just some anecdotes that I've heard with transportation issues. So it's not a perfect system. There are resources, but there's still a lot of ways we can close the loop on transportation challenges.
Thank you very much for that answer. Since I don't have additional questions from the audience, we're going to go to Pat to kind of round out and close our program.
Thank you, everyone. On behalf of the School of Nursing, the School of Dental Medicine, and the School of Medicine, the Alumni Association Board, I want to thank you, our presenters, for this very informative forum. This now concludes our interprofessional program on successful aging. For any additional information, please contact any of our school staff representatives listed on your screen.